All right, we're going to get started. Thanks everyone for coming to the stroke lecture series. I'm Sandeep Khot. I'm going to speak today on the trajectory of stroke recovery. And before we start, I just want to say we're going to try something a little bit differently, where one of the reasons we've always asked people to not ask questions in the middle of the presentation is because, out of respect for the remote audiences, which we have a good 10 to 15 usually tune into our talks. But this time we're going to actually try to get people to talk in real time by just having them call in. So a few people have called in, and we'll unmute them when we ask for participation. So just FYI, feel free to talk, especially when I ask you questions. They've called in, yes. Oh, there's a call number. It's the call number is 315-1785, 206-315-1785, and the code is 855473. So if you are interested in calling in, you're welcome to. Like I said, you'll be muted until we ask for your input. All right, so a little bit about the trajectory of stroke recovery. Just some disclosures. First, none of which are directly related to this talk. And then I just want to take a minute to also just say thank you to Min Pham, who was our IT and AV expert. Min we've run the lecture series for about 11 years now, and Min was the AV person for 6 of those years. And was unbelievably helpful. You probably walked by him on your way to food, but Min did a really good job to make sure we were webcast to our remote audiences, which sometimes can be up to 40 sites. So special thanks to Min, and we hope him the best.
So are we still webcasting?
We are webcasting, but now it's with Adrian helping Rachel and I. And the lecture series may change next year, and there may not be a webcast component to this. And so just the 6 years that Min helped us was extraordinary, because I don't think any of us ever worried about the webcast. And so just a special thanks to Min, who just did a great job. All right, so I'm going to start with a case, and this was a case that we had some time ago, and a conversation we had on the wards with the patient after a stroke. And so I'll be talking a little bit about that. The case is a 73-year-old woman who had atrial fibrillation, who developed abrupt onset left-sided weakness, and had a stroke scale of 12. For those keeping score at home, the stroke scale was for partial facial palsy, lower facial palsy, no movement in her left arm, a little bit of movement in her leg, but not anti-gravity, and then mild to moderate sensory loss, mild to moderate dysarthria, and mild extinction and inattention. So this was a fairly severe stroke. She had a CT angiogram about 5 hours after the onset, which showed a terminal carotid and proximal MCA occlusion. And then she underwent a successful endovascular treatment, a mechanical thrombectomy, which the people who are on service right now probably have seen many of these cases where she wasn't a TPA candidate, but she was a candidate for actual mechanical thrombectomy. And this is some imaging from her case. So the first one is a picture of a catheter angiogram showing injection of the internal carotid artery, a sagittal view, and so the image shows the cervical carotid going into the intracranial carotid, and this is the carotid siphon where it kind of turns course, and you can see the ophthalmic artery right here, and you can see that it abruptly ends, and so this is a terminal carotid occlusion. So nothing in the middle cerebral artery is filling. But after successful mechanical thrombectomy, this is what we like to see, a complete restoration of flow to her middle cerebral artery, and even you can see her PCOM. Oops, sorry. And then the resulting later that evening, infarction of some deep parts of her middle cerebral artery, but sparing of most of the cortex. This did extend down into the internal capsule, the infarct. And so really someone who is not moving the arm and leg at all to the next day having an infarct that spared a lot of that cortex is a very good outcome. However, the following day, her speech is dysarthric. She has a left facial droop. She cannot walk or use her left arm. She can weakly flex and extend the arm when it's supported. And she can weakly raise her left foot off the bed. So anti-gravity now in the left leg. And then can use her arm. But she requires maximal assistance with all her self-care tasks. All right, so Jean, you're going to have to be the one to do this. If you could unmute, because we're going to ask for input. And there is no right answer to this, right? So this is something she asked us on rounds the next day. She said, how am I going to?
Sorry to interrupt.
Yeah.
They're listening over the computer?
Correct.
So then we don't have to unmute us at all. We just have to turn up the volume.
Yeah.
Somebody.
So what advice do you offer her and her family regarding her recovery from her disability? She's asking, what am I going to look like in 3 months? And so what advice would you say to her given this exam, what do you think she's going to look like in 3 months? And so anyone in here can talk. I can't quite. The remote audience, you can also just speak up directly into your phone. Any thoughts? Yeah, that's a good idea. What do you think her best case scenario is? In 3 months, she can barely move her arm. She can lift up her leg against gravity. And this is a day after her stroke. Not all at once, please. So it's good. So she'll likely walk again. Is she going to be independent? Best case, yeah. Okay, so we told her that, well, actually not we, I just blurted out in rounds. I think when I see you in 3 months, you're going to be completely independent. And then after rounds, I realized I didn't have any data to support that. So that's why I decided to do this talk. What is the data? What do you think her recovery is going to look like? Let's start with her gait. You can put the volume back down. So let's start with her ability to walk. So after a stroke, about 35% of stroke survivors who have initial leg paralysis do not regain useful function, and about 20 to 25% unable to walk without full assistance. And this is from a meta-analysis of about 14 studies, and they looked at studies that had at least 3-month follow-up, but most of the studies had at least 6-month follow-up. But what they found is that it really depended on how much function you had from the beginning. As you'd imagine, the grade of paresis initially really determined how you look in 3 to 6 months. And so if you had some effort against gravity, so she at this point, the next day, has some effort against gravity, the likelihood is in these people, first of all, about 65% of them had some recovery after 6 months. But among the people who had some effort against gravity, some motor recovery, about 44% of them had complete recovery, about 29% had partial recovery, and then about a quarter had really no change or actually got worse. This is an old study, but you can see about 75% of people who had some motor recovery after their stroke had partial or complete recovery at 6 months down the road.
I'm having a little trouble with the percentages here. So 35% had no motor recovery?
Correct, yeah.
How is that different from the 20% that had no change?
So this is among the people who had motor recovery, some motor recovery. So
no change? I don't understand. That sounds like no motor recovery.
Yeah, I think it's that they. That's a good point. So that they, the 20% who didn't have any change. Yeah, I guess that they had some recovery, but I think this is actually disability. Sorry, this is part of its motor recovery and part of its disability. So they still had no change in their ability, in the fact that they were disabled, but they didn't go on to independence. But this wasn't. So if you had some movement, you had a 75% chance of going on to have complete motor functional recovery. One of them is neurologic, one of them is functional.
But these data are accounting for people who had intervention.
No, and this is a key point, which I'll get into in a lot more detail, which is people who had, some of these old studies are only dealing with, no revascularization, no recanalization. So this is just, and I'll talk a little bit more about studies that have to do with potential interventions. So this was a study done in Copenhagen, and in Copenhagen it's pretty interesting because you're hospitalized, and you have hospitalized for a long, long time, and you get therapy throughout your hospitalization, and then you're either discharged months down the road to either home, 80% going home, and about 20% going to nursing home. But this idea of getting out of hospital early is not done, and as a result, what they did in this study is they looked at the Barthel Index, 10 items, maximum score of 100, and mostly motor, and looked at how much recovery would you have and at what time point would you have maximal recovery. And so there's 3 different time points here, 3 different graphs here. One of them is all patients, an asterisk. The circles are people who did not walk initially, and the squares are people who initially were able to walk with assistance. So how long did it take for people to get to their maximal recovery? This isn't saying that they were independent. This is just saying how long was it till their maximal recovery. So the time course of recovery of survivors in people who are not walking and people who are walking with assistance, and then all patients. And what you can see is that 80% of, you could, let me rephrase this. If you had 80% reach their best walking within 6 weeks from their stroke onset. 95% reached it within 11 weeks. So if you are going to walk, it's likely that you're going to walk by 12 weeks. If you after that, the likelihood is probably much lower, but not impossible. And so what advice do you offer her and her family regarding her recovery from her gait disability? Overall, based on her initial exam, some anti-gravity strength, so moderately severe paresis, she has about a 75% chance of partial or full recovery in her leg function, and her maximal gait recovery should occur by 6 to 12 weeks. And again, this is, as we point out, this is old research, but I'm going by her exam the day after, not her initial exam. All right, the following day, I mentioned that she also could not use her left arm, but she could weakly flex and extend it when supported. So what advice do you offer her regarding her recovery from her arm dysfunction? Will she be able to grasp objects? Will she be able to use the arm, have some dexterity of the arm? Do you think she'll be able to, let's say this is her left arm, this is her non-dominant side. Will she be able to use it to support objects if she's grabbing her right arm? Any thoughts? She did not. She initially scored for neglect, 1 point on her stroke scale. But when we're seeing her the next day, that we can't really pick it up. And the MRI did not show any cortical infarct. She's very aware of her deficits.
The best case?
Best case? Yeah.
And if you're mentioning the left arm strength, you're not saying anything about her hand strength.
Yeah.
So what is her hand strength?
So the next day she can move her arm a little bit. She has very little movement and extension of her fingers. And I'll go through a little bit more detail. We saw her for 6 days before she went to rehab, and by the end she was able to lift her arm against gravity, and she was able to use her fingers a little bit more. But she was able to weakly extend her fingers, and she's able to lift her arm very weakly after the first day. So what do you think? Do you think she'll be able to use it functionally? Most people are nodding yes. Probably. Best case, probably use it functionally. Worst case, maybe not functionally, but maybe supporting using the other arm. Okay, good. So there's data for this as well. So about 65% of stroke survivors cannot incorporate their effective hand into usual activities, and poor outcome is probable when hand has no movement or only slight flexion, like she's talking about, with no opening by 4 weeks. So should the point of therapy be training that paretic arm? Should we be focused on training it, or should we be focused on compensatory strategies for their existing deficits? Should we be teaching her how to transfer from a bed to a wheelchair for mobility? Should we be teaching about one-handed self-care, using the good arm, the unaffected arm? And so this is where should the focus of a rehab be? So this was a study that looked at about 100 ischemic stroke patients, and they used the ARAT, which is the Action Research Arm Test. And this specifically looks at dexterity of the hand. And what they were trying to do is look at a model for what could predict the dexterity of your hand at 6 months based on your initial exam. So looking at this, and overall the ARAT looks at a few things: grasp, grip, pinch, gross movement. But greater than 9 is some dexterity, less than or equal to 9 is really no dexterity. So they kind of dichotomized their outcome. And they looked at a bunch of things, including the neuro exam. They looked at the motricity index, which looks at strength, the Fugel-Meyer, which is really synergism of the arm completely. They looked at thumb finding tests, so inattention. And they also looked at ADLs by the Barthel index. They all put all this stuff into a model, and they tried to predict who is going to likely have some hand dexterity at 6 months. Just looking at the population, and it's a bit small, but if you can see that these are pretty severely affected patients. So total anterior circulation infarct, about half of them. Partial, about a third of them. Lacunar, very small, but you can see that, and then the amount of aphasia, about 75 out of 100, about 50-50 for inattention, so a lot of cortical findings. And then these bottom two things, the FAC is ambulation, so none of these patients were ambulatory at admission, and none of them, the ARAT is the dexterity, none of them had a hand dexterity. So these are fairly severely affected patients. So can you predict with this model how they're going to do in 6 months in terms of their arm dexterity? And so just a little bit about the Fugel-Meyer. Some of you have probably done the Fugel-Meyer, but it's a pretty complicated. This is all are scored 0, 1, or 2. And for the arm, you can have a maximum score of 52. For the hand, 14, so a total of 66. But it's looking at a lot of arm synergism, so multiple arm contractions to do some of these, so like forearm pronation, to do some of these things. But it's a pretty complicated scale. So what do they find? So first of all, about 38% had some recovery in their dexterity in ARAT greater than 9 at 6 months. And about 11% of these had complete recovery, and ARAT is 57. So 11% of 38, about 4% or so had complete recovery out of this group. So pretty low chance of complete recovery. But how about just some dexterity? About 40% chance of having some dexterity of the hand. When they looked at what factors were probably the most contributed to it, it was 2 scores: the Fugel-Meyer score and the motricity index score. Again, the motricity index is more strength, Fugel-Meyer is more arm synergisms. And so what did they find? And again, this gets a little complicated. You have to follow these scores, but if you had an MI score of greater than 25 in the first week, MI leg score. So if you were able to lift your leg against gravity by week 1, or you had a Fugel-Meyer score of greater than 11 at week 2, increasing to 19 at week 4, this increased your positive predictive value of having some hand dexterity from 74 to 94, 0.74 to 0.94 at 6 months. And they really found no change in the probabilities after 5 weeks. So after 5 weeks, most of the recovery happened in those first 5 weeks. So how could you translate this? An MI score greater than 25, and the leg at week 1 had good probability of an ARAT greater than 9. So translation, people who develop some voluntary movement of the hip, knee, or foot in the first week after stroke have about a 74% chance of regaining some dexterity of the hand. Conversely, the absence of voluntary leg movement reduced the probability to 14%.
So isn't that kind of an unusual thing to say to patients? If your leg's getting better,
Yeah.
I think your hand's going to get better.
Yeah, it's a very strange thing. This is just what they found with their model.
How many
Predicting the hand.
This was a little over 100. If you had a Fugel-Meyer score greater than 25 at 2 weeks, increasing to by 4 weeks to 19, again, the strongest clinical indicator after the first week was your dexterity and the severity of paresis in your arm. So if at week 4 you had some return of arm synergisms, you had a 94% chance of having some dexterity. 94% of patients would have return of arm synergisms. Those lacking motor recovery by week 4 really had poor outcome at 6 months. Why is this important? Partly because we never really say this to patients. And I'm talking about the flip side. I just saw a patient in clinic 3 months after a stroke, went from hospital to rehab, saw multiple providers. 3 months, she was densely paretic in her arm and leg, no movement at all at 3 months. And she repeatedly asked me in the clinic, when is this going to get better? And I said, has anyone ever told you that this is not going to get better? Yeah. And this was intratuber hemorrhage, but I said, the likelihood is this is not going to be functional ever. And the likelihood is you're not going to walk, and so, but as a, again, likelihood, this is not, I wouldn't.
You say that you saw her when she was in the hospital?
I saw her within a few days. You can blame me for part of it. So what advice do you offer her and her family regarding a recovery from her arm and hand disability? And I thought that was a nice picture. When are you going to be able to use your iPad again? So based on your initial exam and some volunteer, remember she was anti-gravity at day 1. Some volunteer movement of her hip, knee, and foot, and return. By week 1, she was using her hand, extending her fingers, lifting it above. I'd say the probability of regaining some hand dexterity is probably 75 to 95%. Maximal recovery should happen by 5 weeks.
I may have missed it. Was there any difference between dominant and non-dominant hands?
I don't think so. When I remember looking at it, they did look at dominant and non-dominant, but I don't think they mentioned that. Not that I'm aware of.
This is natural course, right?
Natural course. Yeah, I haven't got to.
Rehab.
I haven't got to that at all. All right. So, what about her maximal assistance with self-care test? What do you tell her about her overall functional disability? Since no one is answering my questions, I'm going to move on and say that only 25% of stroke survivors return to the level of everyday participation in physical functioning of community-matched non-stroke persons. Now, this is different from the Barthel Index, because if you look at the Barthel Index, 40 to 50% of people by Barthel Index achieve independence. But what I'm saying 25%. And why am I saying that? A part of it has to do with the scales. And so let me just talk a little bit about, this is the study I mentioned in Copenhagen where they looked at the Barthel Index every week while you were in the hospital. And there's a lot of different graphs here, but the ones that are probably, this is the severity of stroke. Mild stroke, these are moderate strokes, severe and very severe. But the black squares are the all strokes. And again, by Barthel Index, you peak in your recovery, 80% of people peak by 6 weeks, 95% of people peak by 12 and a half weeks. But what's wrong with the Barthel Index? This is the Barthel Index. It's all motor. There's nothing in here about IADLs. There's nothing about shopping, grocery shopping, using a phone, using your iPad. There's nothing in here about doing your bills, the things that are important for recovery beyond just, this is, even though this is a functional outcome scale, it's just not encompassing anything. It's not encompassing emotion. It's not encompassing really much memory or cognitive stuff. But and even the Barthel Index, some things get better than others and quicker. So they looked at, this is a study where they took 163 ischemic stroke patients. They looked at the 10 ADLs by Barthel, and 7 of them, and they all kind of have different peaks, but 7 of the 10 peaked at 3 months. But 2 of them peaked at 6 months. Dressing and stairs, it took 6 months before people reached their peak recovery. And then, I've never thought of this, but bathing is the hardest thing apparently to do because you didn't reach your maximal recovery for bathing until 12 months. So things can change, and especially certain parts of your motor recovery can change. This is what we use in our hospital, the functional independence measure, the FIM. If neurologists are focused on the NIH stroke scale, rehab people are focused on the FIM. The FIM is 17 items, 18 items. 18 items. Each one's ranked 1 to 7, so your maximum score for motor is 91, your maximum score for cognitive is 35, and it does include stuff like comprehension, expression, social interaction, problem solving, memory. but even the FIM has a ceiling effect. And so even the FIM is not a great measure of stuff like emotion or IADLs. And so what people decided to look at is what happens when you reach maximum recovery, and are you really fully recovered? So this was a study where they took patients who had reached a 95 by their Barthel index, and in Kansas City, and they looked at these patients, and they compared them using what's called the stroke impact scale. So if the Barthel index has 10 items, the FIM has 18 items, the stroke impact score has 59 items. So 8 domains beyond physical. So this is the physical one: social participation, communication, emotion, memory and thinking, mobility, ADLs and IADLs, hand function and strength. A lot more beyond just the Barthel or the FIM. And I looked at these people, and like I said, they only recruited patients who had strokes who achieved greater than 95 on their Barthel index. And they compared them to community dwelling non-stroke patients, one from the VA, one from an HMO. And they compared them using, for those patients, they didn't use a stroke impact scale, they used the health impact scale. And the 4 things that were worse in the stroke patients, and this is at the comparison was 6 months down the road, was your hand function, your ADLs and IADLs, your social participation, and your physical function. Again, these are people who are deemed to be fully recovered from their stroke. Yet for these 4 things, and then they adjusted for age, sex, and diabetes. And I'll show you in a second, age and diabetes were probably the biggest contributors. But even after adjusting for those things, these 4 aspects were worse in the matched stroke patients compared to community dwellers. And for example, just looking at ADLs and IADLs, the biggest contributors: age and diabetes. And so this is a patient that we've been talking about who's been in her 70s. So age is a huge contributor on her recovery. So what would you tell her in terms of her overall functional disability? Well, based on prior studies, her probability of regaining functional motor recovery probably between 40 to 50%. And this is, again, more based on the Barthel index, but likely within 12 weeks. But certain aspects of function, like her independent ADLs, her participation, her overall physical function, and then specific motor functions like her dressing, bathing, and stairs, they may take much longer to improve. But most recovery will happen within 3 months. So a lot of this just has to do with the scales that we're using. All right, so I'm going to switch gears a little bit and talk a little bit about, would you advise her about anything else that can improve her recovery function, especially her ADLs and IADLs? And this is probably worth just talking about disability in general. This is a nice table from the Lancet, which talks a little bit about something called spontaneous neurologic recovery. And spontaneous neurologic recovery is this non-linear recovery that happens within the first few weeks of a stroke, where there is 2 or 3 things happening. One, there's restitution. There's restitution, which is basically restoring the functionality of these damaged neural tissue. And then substitution, you're reorganizing the pathways, these spared neural pathways, to relearn lost function. Now, a lot of this stuff, restitution and substitution, happens based on time. It doesn't require therapy. It's just the brain recovering, and this is very poorly understood. What improves this? What worsens it? This is all pretty poorly understood. But a lot of rehab, if we're focused on a stroke scale, probably measuring restitution, substitution, compensation is what rehab is focused on. And compensation is improvement of the disparity between your deficits, your impaired skills, and the demands of your environment. And that's really what rehab is focused on. Trying to get people, and this is after that spontaneous neurologic recovery, trying to get people to, after this period of weeks where they have initial recovery, try to get again back to their normal environment. And so this was a study where they looked at what percentage of each of these areas of recovery is solely dependent on time. And so they looked at patients who, within the first 16 weeks of a stroke, of an ischemic stroke, and they looked at a lot of things. They looked at Fugl-Meyer, which is, again, synergism of the arm, the motricity, strength, Barthel index. The FAC is ambulation. They looked at letter cancellation, so inattention, hand dexterity. They looked at all these things every week for 16 weeks after a stroke. And what they found is that and they put these into a model, and what they tried to see is within the first 16 weeks, what percentage of this is solely explained by time. And I won't go through the math because as promised there would be no math. But overall what they found is that 42% of your change in your functional recovery by the Barthel index is explained solely by time. About 25% of your arm recovery, about a third of your leg recovery, and 16% of your reduction in visuospatial inattention is explained solely by time. And so, and this is the one curve that goes down is the inattention. It's good that it's going down. It's supposed to. And so, if the first 6 to 10 weeks you're having this spontaneous neurological recovery, why is this important? Because if you start, and I'll start going through some of these trials, some of the trials specifically are only recruiting people after the first 6 months. Because some of the trials, and I'll go through them, like Vectors or Avert, have actually shown harm when you recruit patients in the first 6 to 10 weeks. When people are going through what's the restitution substitution, that if you try to get these people mobilized too quickly, that maybe that's actually harmful. There's a time window when people will actually improve. Other studies like the VA robotics study and this one called, which I'll talk about, the Excite study, all recruited at 6 months. Why? Maybe because you're getting outside of that spontaneous neurological recovery. Does that make sense? And so, yeah, and exactly, and then this is one, and I'll talk about some of these studies.
You also want to find ways to stimulate.
Exactly, and some of that's backfired, unfortunately, especially, which I'll talk about, the constraint-induced motor therapy, where it was useful when it was done at 6 months and harmful when done right up front. So the Excite versus the Vector study. So I'll talk about these in a second. So again, so what can you do? So let's focus on after that 6 to 10 weeks. After that first few weeks, when you now are trying to get people to really specific rehabilitation interventions to get them back to the activities of daily living. And so one of these studies is looking at constraint-induced movement therapy. And so if you haven't heard of CIMT, it's you restrict the unaffected limb. And the initial studies, which were done by Taub in monkeys, where they had their limbs, they had somatosensory deafferentation of their limbs. And what they were able to show is that there would be expansion of the cortical motor area. Those studies, they'd actually restrict the unaffected limb for 90% of the time. 90% of waking hours for 14 days, and 6 hours of therapy a day for 10 days. And you have to be able to at least extend your wrist, your thumb and fingers, and you have to have absence of cognitive impairment or excessive spasticity or imbalance. Since then, they've realized that the CMT is probably a little too tiring and labor intensive, so they've had a new protocol, the CMT protocol, which is a half hour, 3 days a week, as opposed to this very rigorous protocol. And so, and I'm not going to go through this in too much detail, but this was the Excite study. And really what I'm showing you, and it's probably a lot more detail, it's hard to show, but they looked at 4 outcomes, and they looked at the Wolf Motor Function Test, WFMFT, and the MAL, which is actually more the motor test is looking at how quickly you can move your arm, and the strength you can move it. The MAL is looking how well you can use it for activities that are important in ADLs. And what they found is that at 12 months, they showed an improvement in 3 of their 4 outcomes. The Wolf Motor Function Test by the performance time and your functional ability, but not in your quality of it. The weight and grip didn't improve. But in terms of your use of it in daily life, the MAL improved significantly at 12 months. They saw it after the 2 weeks of treatment. They saw it again at 4, 8, and again at 12 months. And they remember, this is the Excite study recruited stroke patients 6 months after their stroke. So well after the stroke, if they did constraint-induced movement therapy, they had an improvement all the way 12 months later. So a positive study.
What was the group? What were the other groups?
They randomized people to just 2 groups, usual care and CIMT.
So they were getting rehab on the unaffected limb.
Correct. So the other group did not get CMT at all, but they got just normal rehab. The vector study was taking the same concept and say, well, if it works, why don't we do it early? And why don't we do 2 arms, one with an intensive arm and one with a less intensive arm? And so, again, they looked at the ARAT, pinch, grasp. They looked, and this is very early constraint-induced movement during stroke. And what they found was that there was really no difference between the control and low intensity in any of these. But surprisingly, these p-values are for harm in the high CIMT group. But the CIMT group that had a high intensity actually did worse in all of these. So the ARAT, total ARAT, the grip, the pinch, grasp, and grasp motor, all of them did worse, some of them statistically significantly worse. Which again got to the point where if we treat people too early, are we actually harming them? And this goes along with the AVERT study where we early mobilize patients. And again, some suggestion of potential harm in those groups. Overall, when Cochrane looked at a review of all CIMT, what they found was that it helped with motor recovery, mostly immediately after therapy, but not 3 and 6 months later. And it suggested this was promising, but not something that necessarily has changed practice. That when they looked at, I think there was 14 trials, 373 patients, there was a suggestion of motor recovery immediately, but not 3 and 6 months down the road. So deemed promising. So if CIMT and I'll talk about some of the other therapies, aren't helpful immediately, but potentially subacute, what about in the chronic phase, now months down the road? Are there any therapies that you can use in that group? So this is just a loaded question. So after a month of inpatient rehab, what's the ideal amount of occupational therapy over the next 10 weeks? 3 hours a week, 1 hour a week, or it doesn't matter? I can tell by the way I'm asking, this actually has been studied, and actually, at least in one study, it doesn't matter. And it's kind of surprising. So what they looked at in this study was the typical outpatient treatment for occupational therapy after that acute setting is about 36 minutes. And out of that, you only have an average of about 12 purposeful actions. It's an unstructured treatment session, but when they looked at just observation, you probably get about a half an hour of occupational therapy per visit, and you only have a few purposeful actions. Let's say you do it twice a week over 10 weeks, so that's an hour a week, so about 10 hours over a 10-week period after rehab. So in this study, what they did is they took patients with ischemic or hemorrhagic stroke. They had minimal hand or finger extension, and they did intensive high repetition task-oriented training. They called it ASAP, Accelerated Skill Acquisition Program, 31-hour sessions of intensive, just doing the same activity over and over. And they looked at 12-month recovery. Now, they compared it to 2 groups. One group was the usual care group, the UCC, and the other group was a dose equivalent usual and customary DEUCC. And really no difference in any of their outcome measures. The Wolf Motor log test, logged Wolf Motor time score, the actual time score. They even knew what the minimally clinically important differences for the time score were, which were, I think it was 17 seconds for a minimally clinically important. And then the stroke impact scale. And then again, minimally important difference was seen in about 70% of people, but the same in all 3 groups. So really no difference whether, and and the amount of therapy was drastically different. The first two groups, the ASAP and the DEUCC, had about 27 hours of therapy over those 10 weeks. The third group, the usual care group, had about 11 hours of therapy. Now, the authors caution that there's a lot of things that we're not looking at. They didn't look at quality of life. They didn't look at health-related, other community participation. This doesn't mean that occupational therapy for earlier or later than this would, but what they do conclude is that for actual motor recovery, using increased therapy, increased occupational therapy, repetitive occupational therapy, about 30 hours a week, was really no difference than 11 hours a week. Again, flies in the face of a lot of what we do. You think more therapy in a subacute setting would have increased motor recovery, but at least in this study published in JAMA, really no recovery based on the three things they looked at. In fact, even when they've looked at patients who go to inpatient rehab, do people do better if they go to inpatient rehab versus this? In this study, they randomized people who are in subacute stroke patients, less than 4 weeks, and they looked at less severe strokes. These are not severe, so only about 13% of the strokes. This is in Belfast. And they got randomized to one or two groups. One was the usual hospital rehab. The other one was early hospital discharge. They discharged them within 8 fewer days of inpatient hospitalization. And they were randomized to a group that got community care support. They saw an occupational therapist, a speech therapist, a physical therapist, and rehab assistants about 2.5 times weekly. So saw them about once a week for about 2.5 weeks. And really no difference in any of their outcomes, Barthel Index, Nottingham, ADL measures, SF36, quality of life. And in fact, the CST patients, the one that were discharged earlier, received more therapy during that period and had more social work contact and had higher satisfaction with their services. So in the less impaired patients, it's hard to even argue that these patients would benefit greatly for inpatient versus outpatient. The problem is we don't have anything similar to what they're providing in our outpatient group. So the Cochrane review, looking at all rehab, all different types of early intensive treatment. So looking at, and I haven't talked about each of these, but looking at motor imagery, looking at this is mirror therapy, and mirror therapy is initially used for post-amputation phantom limb, but you put your impaired arm in a box that has a mirror, and you do activities with your non-impaired arm or both arms. And it's been shown to improve recovery. But looking at that, CIMT, repetitive transmagnetic stimulation, or direct current stimulation, looking at all these different therapies, the Cochrane review came out and said there's no high quality evidence can be found for any interventions that are currently used as part of routine practice, including the amount and the content of motor training. At this point, you're probably saying this is the most depressing talk I've ever been to. Like what is there to provide your patients? And when you're asked about these things, when patients come into clinic and they say, what else can I do? The reality is there's not great evidence to provide for any of these therapies. It's not that some have been studied, some have been studied extensively. It's a problem is just the difficulty in finding treatments at the right time window. And so looking at this, this was a nice paper in the New England Journal, which talks about what are some of the things you can do. Well, this talks about monitoring distance or other markers of recovery, progressive practice for speed and task, strength and endurance, and then environment-based tasks. And so things you can do 1 to 6 months, and then even after 6 months, fulfilling their usual roles and out-of-home activities. So there are things you can encourage, but there's no great evidence that there's anything to make that recovery go any faster. The last thing I'm going to talk about is if there's, each of these periods, what about after 6 months? And this graph shows some people get better, some people plateau, some people get worse. Well, maybe it's not so simple. And so this is a study that Will shared with me, which is in Press. And it's an interesting thought, which is they took the cardiovascular health study and they examined accelerated disability after stroke. And so the cardiovascular health study had over 5,000 Medicare eligible patients, and they followed them for a mean of about 13 years with annual assessments. And they took the patients in this group, about 400 of them had ischemic stroke, and they wanted to compare them to 400 who had an MI. And they wanted to look at their disability trajectory. What happens after that recovery? So the traditional view is that you have this immediate increase in your disability, then it starts getting better, and then you may slowly have progressive disability. But maybe if you compared MI patients to stroke patients, maybe there's an accelerated disability among stroke patients. Maybe they get worse faster. And what would account for this? A lot of things. Remember, stroke is ultimately vessel dysfunction. So you can have vessel dysfunction, you have and this is not just saying you have more strokes, but you have vessel dysfunction causing white matter disease. You have neurodegeneration, the actual stroke causing continued injury to the brain, local and systemic inflammation, progressive cardiovascular impairment. You have, because you're bedridden for so long, you really don't have the endurance anymore after that. And then Will's favorite term, covert brain infarcts, not silent, covert, that they don't, these infarcts can accumulate in your brain without you knowing that you're having these infarcts. They're in clinically silent areas of the brain. And so in this study, like I said, they compared patients who had strokes and MIs. And what they did is, I'm going to go back one slide. They took out the disability in the first 6 months just for the stroke patients. So because they were checking this every year, they looked 12 items, ADLs and IADLs. And when they looked at them, each of these assessments, they had an average of 4 assessments before their event and 4 assessments after their event. On average, 400 stroke patients, 400 MI patients. But for the stroke patients, they took out the 6 months right after the stroke. They excluded those because they didn't want that to contribute to the slope afterwards. And what did they find? Well, overall, the change in disability score before their stroke, 0.06. The additional annual change after their strokes, 0.15. So 0.21, more than tripled their disability after those first 6 months when they looked at the trajectory. Whereas MI, 0.04 before, 0.02 after, really no change in the slope of their disability after an MI. And they adjusted, for a lot of different, things. Diabetes, arthritis, depression, C-reactive protein, mini mentals, MMSE scores, social network, all kinds of things, and found more than tripling of your disability after a stroke. And they're not the only ones who found this. They've published, the same group has published using the Northern Manhattan study, again, an accelerated disability after stroke. And more recently, they've looked at cognitive recovery. Cognitive recovery, much more accelerated after a stroke in stroke patients compared to MI patients. So maybe that after the event, the change in disability is steep, and then you don't return back to that same slope. You actually have an accelerated disability after that, which is even more depressing. And so this whole thing of restitution, substitution, compensation, it's something that warrants a lot of research. And I'll just last plug, which is my soapbox, which is, if you looked at the amount of research that we spend, amount of time, the amount of in conferences talking about, and it's very important, this case demonstrates how important it is, that first few hours after a stroke, extremely important. This woman spared her entire cortex because of the intervention. But you'd have to say the research is very needed, and it's a great area to do research in. It's a sexy area to do research in. And you go to the research meetings, people applaud when people present this stuff. Equally, the vast majority of the patients we see on the stroke service, they didn't get an intervention. They suffer, and we have very little research to offer them. Research is really needed, and it is not sexy in any way. There's no one applauds, there's no big changes, and despite all these different treatments, CIMT, motor imagery, mirror therapy, really nothing to be able to, how can we bend these curves? How can we make people recover faster in the subacute setting and the chronic setting, if we know that maybe disability is even worse after a stroke? I think that's it. This is a picture of a sidewalk of moon shadows during the eclipse outside of Harvard, right near the bus stop. But with that, I'll be happy to take any questions.
Keep you around.
Should they do a trial of no therapy versus standard of care?
I don't think that would be very popular. I mean, and none of the things. The question was, should you do a trial of no therapy versus standard of care? You know, my general feel is after looking at all this literature that first you can do harm by doing too early, too aggressive therapy. But after that initial neurologic improvement, there probably is a point where you can bend these curves. The question is how to bend them. I mean, what my research is focused, I can't give a talk without saying CPAP, is, you know, can you bend the curve with a treatment that's modifiable? Can you bend the curve of recovery, the subacute setting, with a treatment that is, you know, the disease that's affecting a large percent of the patients, like CPAP? Or could you bend it with, you know, fluoxetine? We've talked a lot about what fluoxetine does for motor recovery. Is that really a good way of testing? And so, and I don't know what the right treatment is, but right now I'd say that there's very little, even in the pipeline, to look at how we can bend these curves. Yes.
I think the answer to David's question is yes.
Should we do it? I don't think. I mean,
You're saying it would be unpopular, but you know.
Yeah, should. I mean, I think. To me, the focus should be more like that Belfast study, where you offer the therapy out of the hospital. You offer that therapy a group that sees you and then it gets the community to give that therapy at home. But I think if you randomize people to no therapy, I do think that people are going to do worse with no therapy. Yes?
Okay, so that was very interesting. I do wonder too about, this is a really abrupt functional change in people, and that, do you think there's a role in just the fact that part of rehab is there isn't any other place for these people to go without level of
So the question is, you know, it's an abrupt change, and is it, as part of rehab should be, you know, there isn't really a place for them to go. Should part of that, and you're asking, should rehab be focused?
Do you think part of why the system works that way is the intense rehab is part of that their next phase? I guess we don't know what they would do.
Yeah. And so, rephrasing it, are you asking, like, should that intense rehab be more reserved for that later phase?
Mostly, do you think that part of rehab is part of the next phase for them to know?
Yeah, should, and yeah, I think should inpatient rehab, and just so you understand inpatient rehab, and most of you probably do, is that most of the people who do inpatient rehab, the goal is to get to functional independence. So it's never to go to a nursing home. In fact, they select people, if it looks like we cannot, in 2 to 3 weeks, that's how the typical stay of rehab is about 16 days. On average across the country, 16 days. If in 16 days we cannot get you to functional independence, to some degree, whether it's adult family home or living with your family, then we don't think you should come to inpatient rehab. Should rehab be focused on that outcome? And I think they are. I defer to the people who work on inpatient rehab, but I think they do spend a lot of time trying to figure out how, you know, what is the ideal place for you to go after rehab. I'm going to take a couple remotes. Great talk. Some studies from rehab suggest a negative effect on muscle relaxants like baclofen. Yes, I didn't come across that, but makes sense that muscle relaxants would have potentially harm. How did the case study person do? Okay, so the case study person went to rehab elsewhere, and I have not seen her in follow-up. I purposely did that I want to see this very blind. And so if you're really interested, you can email me again at skhot@uw.edu, and I'll be happy to tell you. I will hopefully see her again, and I'll see how right I was or wrong I was. With both studies, it is early high intensity that has a negative effect. We do not provide high intensity early on. Yes, that is true. We do not provide high intensity early on. And I think there's been a push, with should we? And I think these negative studies really suggest, avert study, vectors, really suggest that probably it is not worth taking rehab to the inpatient neurology service because, I mean, I think he's saying some of these high intensity therapies that like vectors and where there's therapy while people are on rehab, but no one would call that high intensity. Like I don't think when someone is on neurology, we're not giving them high intensity therapy. They see a therapist. Oh yeah, definitely.
Okay, so some of our patients go there on day 2, so that's.
I would say that's an exception, but yeah, I mean, having recruited all these patients for the last year and a half, I'd say that's an exception that people do go there on day 2. But it does happen, and I think, do we do any of them any harm? That's a good question. I never thought of it that way, but usually we think they're ready for it.
But we never send people home before we get them into rehab. Like someone who's good enough to go home for a week and then come back, we never do that. And the parents and insurance issue.
Yeah, and so the question is, we don't send people home for a week and then have them go to rehab. Correct. We don't typically delay their rehab because of this potential worsening.
You mean as opposed to them going to they go to SNP and then they might come back?
All that, no, we never, but I'm thinking about those who are good enough to go to rehab. But it might be too early. We
I
never,
mean, at the youth, people definitely go and come back in, but they have to be part of that mechanism to, that they capture you and reevaluate you in clinic and decide whether or not to bring you back.
but those are those who are not good enough for inpatient rehab. They're so impaired, they go to nursing home, then they come to rehab. So this is all an insurance decision. It has nothing to do with
Science.
science. Which is
Yeah.
really amazing.
So there's a
All based
discussion saying that much of this decision to transfer someone to rehab is much more based on insurance than it is based on some of these studies, which I think that's undoubted. That very much this is, even the stuff with community, reintroducing people to community very much is based on the therapy they get is not probably influenced by even that eye care
It's
study.
fascinating how frustrated patients are to us, about not getting into rehab.
Correct.
Well,
They don't-
and they may have unrealistic expectations about what we have.
Well,
But
yeah.
where did those come from, those expectations?
Yeah, exactly. We're feeding them.
All right, good discussion here, but we're going to wrap it up. Thank you guys very much.
Thank you.
Please fill out